I believe overall we have seen an increase in the use of dabigatran after the availability of idarucimab. Recognize, however, that we know that all 4 DOACs are effective and safe. And from a clinical standpoint, we also recognize that although having a reversal agent may provide comfort, especially to our colleagues in the emergency room or in the trauma stations, their overall use will be quite low. Praxibine is obviously the reversal agent for Pradaxa or dabigatran. It is effective. It acts quickly in terms of halting the anticoagulant effects of dabigatran or the direct thrombin inhibitor. And it's also very specific for dabigatran. I don't have any personal experience using the drug, but I've reviewed significant clinical data and understand that it is used in high-risk populations at times of significant bleeding, and it is effective at reversing the bleeding. When I speak to my patients about the options for various DOAC therapies, I do indicate that some of the agents have a reversible agent and some don't, not yet at least. Patients who are concerned about bleeding risks, who are concerned about side effects from intracranial bleeding or GI bleeding, often find comfort in having in being on a medication, in being on an oral anticoagulant that has a reversal agent available. So in those situations, I will oftentimes prescribe the anticoagulant where reversibility is available. The availability of other reversal agents will provide greater confidence to our patients that they will be on a DOAC, they will be on an oral anticoagulant where a reversal agent will be available in case they ever need it. When we make a decision for a particular NOAC therapy, we are confident that the agent will be effective and safe. The safety data now for these agents is based not just on the clinical trials, but it's also based on the large amount of post-observational data that has come out in the phase 4 studies. Certainly, the availability of a reversal agent is important, and it can be important in certain life-threatening situations. It is why when I have the decision about which oral anticoagulant to prescribe a certain patient, I always mention the availability of the reversal agent, especially for a drug like dabigatran. And in the end of the day, I just want the patient to be maximally comfortable with the agent. Oftentimes, there are concerns and questions related to potential bleeding effects, other potential side effects, and I believe that by providing them the assurance that a reversal agent is available, that oftentimes convinces them to continue a certain medication, to continue an anticoagulant medication. Our atrial fibrillation patient population is generally a group of individuals that are elderly and are at risk for other cardiovascular comorbidities. Oftentimes, these are patients that require other cardiac procedures, whether it's ablation procedures or cardiac catheterization for stent placement. In individuals who are taking a DOAC, it would be ideal to have available in hospital a reversal agent. We recognize that these procedures can be complicated by cardiac perforation or other bleeding complications, and as a result, the availability of reversal agent can be very important in those situations. We appreciate how best to prophylactically treat our atrial fibrillation patients that are at a high risk of systemic embolization or ischemic stroke. We understand the importance of anticoagulation therapy. However, moving forward, I think we have a few challenges. First, we need to ensure medication compliance and adherence in our populations. We need to emphasize to caregivers across the country that it is important to maintain anticoagulation in these individuals. And at the same time, we also need to emphasize to our patients the importance of anticoagulation use. In addition, we need to start identifying those individuals that do not have clinically overt atrial fibrillation but are still at risk of developing ischemic stroke. Ischemic stroke may oftentimes be the presenting manifestation, may be the first manifestation of clinical atrial fibrillation. And identifying those individuals before they have their first clinically severe event that could result in significant disability or even death, I think is important so that we initiate anticoagulation therapy as early as possible.